Cool.
Good
Right.
luck, and we won't see you later. We'll see you soon.
Going live in three, two, one, live.
Good evening, everybody. So, welcome to this Legs Matter webinar on day 4 of Legs Matter Week. So, this evening, the plan is to just talk about data and why is data so important when it comes to lower limb care. So, I'll introduce myself first. I'm Kate Williams. I'm the Associate Director for Wound Care at Accelerate, and I'm joined by Julie Hewish, who is the National Clinical Lead for the Transforming Wound Care Programme. So the plan for this evening, we've got a short recording of a conversation that myself and Una Adderley, who's the former lead for the National Wound Care Strategy Programme, Una and I had a conversation last week, which we recorded because she couldn't join us this evening, just thinking about why data is important at quite a basic level, but then how it can really change practice and really what might be missing if we don't collect the data. So we're going to play that recording now, and then if you've got any questions, please pop them in the chat, and then Julie and I will have a conversation afterwards and pick up some of the bits in the recording, answer some of your questions, and just generally have a chat. So if you can play the recording, so thank you. Thank you so much for joining me today for this chat about data. So what we want to try and unpick is why data really matters in relation to leg and foot care. So
people
I
think
know
it's
you've got
such
a
a
lot
dull.
of experience.
But people think data is such a dull subject. But actually, it's so important because we can only improve what we can measure. So if we don't have good quality data, it's going to be very difficult to tackle an issue because we don't know
Yeah.
where we are and we don't know what better, whether we've got better or not. And I think what's really confusing about data is there's so many different types of data we need. Obviously, we need clinical data, all the stuff we write in our notes, so the next clinician coming in knows what you've done. So obviously we need that.
Yeah.
But we also need workforce data, because if you're a manager managing a team, you need to know who's doing what, can you deploy your workforce any better, and so on. We need product data. We need to know what we're using on patients. And we also need experience data from patients and carers, because we need to know, is the service we're providing good enough? So you can imagine that's so much data. I remember when we were looking at this right at the beginning, 6, 7 years ago, there was something like 30 or 40 different things we came up with. But actually, we do need all that data, but we don't need all that data to quality improve. We need to decide which are almost the key items that we really
Yeah.
need to focus on so that we can make comparisons. And that's
I've
the
made
hard bit,
that
I think.
mistake before when I've just got data,
Yes.
but not all of it's really helpful,
Yeah.
but all of it was very time consuming.
Yeah.
So it's getting that balance right, isn't it, between data
But
and
some of it
helpful
probably was
information.
really helpful, but
Yeah,
not because if you're the nurse coming in next, for example, you want to know what's been put on that wound, but do you actually need that in order to do the quality improvement work? So it's different
yeah.
data items and because of course we forget that you need data to provide information. They're not the same thing. Data gives you information, and it's possible to just drown in data if you don't work out what information are you actually trying to get in order to do whatever it is you're trying to do.
Yeah. So, how big do you think the data gap is, and
Mm.
why?
That's a really good question. If we look at the data gap of, do we know how many people there are with leg and foot ulcers? No, we can't say with any certainty. There's been several large, decent quality studies, but even they don't agree with each other. So we know we've got a problem with our data. Too often there's either no data, or the data that does exist is patchy or of poor quality. And the reason for this is most leg and foot ulcer care is in the community or in
Yeah.
general practice. So lots of different data systems that don't necessarily collect data or code in the same way, or even paper-based. So it's nothing wrong with paper, but you've got to make sure it's
Always
coded properly.
surprises me, yeah.
Yeah,
When people are still using paper, you just don't think that still happens.
yeah. It does,
Yeah.
for often reasons. But so if you're not coding those notes, and that coding isn't being entered in anywhere, and it's not the same codes being used.
Yeah.
You don't know what it's like. It's a mess. You know, trying to work out what is actually going on and measure it is very difficult.
Yeah, the coding thing is a friend of mine described coding once as um if you don't use it, it's like you get so the system is like your garden shed, and without coding, it's just everything chucked in. You can never pull anything out again. Whereas with the coding, everything you've got a lovely tidy shed and it's all labelled, and the bits you need, you can just put your hands on, pull it out. So that really, for me, the penny really dropped with that as to why the
Yeah, that's a really
coding,
nice
instead of just
analogy.
waffling on writing War and Peace, which is great for the next person who reads it, but it's not great for any useful information.
It's not used for
Coding.
quality improvement
Yeah,
because you can't, it's
yeah,
not usable. It doesn't produce it's difficult to produce usable information. It can do,
yeah,
but you've got to actually work your way through it. Whereas actually if you can just put some codes in for some key things,
yeah,
it's working out what those key things are and making sure that we all measure the same the same key
yeah,
things using the same codes. So it is an issue. And of course, the other thing that's interesting is even when people are using digital electronic systems, they're very often using different templates and they're not
mm,
standardized. And even within one provider, the same provider, but you can have different templates. It's, why don't we have a national template for this or something? Just so that we know um, that we're all doing things in the same way. And could we please design this template in a way that works with clinical practice? Because then
yeah.
we're all guided to try and put it in the same way. We can start to make meaningful comparisons and measure.
It's that perfect balance, isn't it, between not too onerous for a busy clinician completing these templates
Yes.
versus enough data to measure impact, like
Well,
feed quality
ideally,
improvement, etc.
yeah. Ideally, what we shouldn't be having to do is audits. Or we will
Yeah,
do audits, but not in the way you go around with a clipboard. What I mean by that
yeah,
is what we should be able to audit is by if we've all had ideally an electronic system that is clinically friendly, so we don't have to do double data entry. We can do our clinical notes. It gets pulled from the clinical notes into
mm,
whenever the audit is done. Then the poor clinician is not having to do that and an audit on top. They just have
yeah,
to keep good clinical records. And that information, because it's been coded correctly, can be retrieved so the audits can be done at arm's length because the data is there. And we know it's doable. We know it's doable because
yeah.
some places are doing that. Yes.
Do you think the sequin helped things, or was that just a temporary?
It's an interesting question. I think it did because I think it drew attention to the issue.
Yeah,
And what I'm hearing now, sometimes I think, oh God, did we make any difference? But then I speak to people like the Transforming Wound Care program who tell
yeah,
me they're getting more and more queries from senior people, senior managers who are starting to recognise this needs to be addressed because there are such opportunities. So I
yeah.
don't think the sequin didn't solve the problem, but I think it was
No,
useful. It raised awareness, which I think
yeah,
is a good thing. Yeah,
yeah. And if you think, how can we start to get a clear? This is such a massive thing, question to ask.
go for
How
it.
can we even start to make it clearer for people? How can it take those first steps towards having simplified coding, same codes across different systems?
Well, I think the first thing that I think, well, let's start at the beginning. There is some good news, okay, in that a couple of years ago, the Professional Records Standard Body worked with the National Wound Care Strategy Programme, the Royal College of Podiatry, and others, and they've developed a wound care information standard that has been published. So we do actually have a standard way of what data should be collected for wound care. That's the first thing. It defines the information record content for the management of wound care across the UK. It's not just England, it's across the UK. And so IT system suppliers are expected to build or customize their clinical systems so that they can allow the recording of this data. So in other words, the skeletal structure is there and is
Yeah,
supposed to be being used. So if you're somebody in charge of a service or even a clinician, but ideally you need to be having a conversation with whoever deals with the IT in your organization to say, are our system suppliers, have they implemented the wound care standard?
Yeah.
because clinicians are not expected to understand the wound care standard or have any more than that. But to have that conversation with the IT people saying, are you aware of this and is it being used? That would make a big difference, because then you're starting to get the tools you need for your data systems. So I
Yeah.
think that is, it sounds techie, but actually it's really about those of us who are on the clinical line actually saying to the IT people, we really want to work with you, but we need the tools for the job. Because if you haven't
Yeah.
got the tools for the job, your life is more difficult.
And with people, if organisations are starting to look at different apps, different systems, and it's the
It could
choice
be
is
built.
enormous of
It
different
is.
systems you could choose.
Yes.
So having that standardised standard is
Yes. They should be built to that standard. That's
yeah,
what should be happening. So you don't want to be buying something that isn't. Why would you spend
yeah,
money on something that actually doesn't do the job it's supposed to do? And the
yeah,
other thing as well is working out, if you're the manager of a service, what are the impact metrics you want to be looking at for your wound care? In other
yeah,
words, because we said at the beginning, God knows how many bits of information you need to care for a patient, but you don't need all of those to work out whether your service is delivering high quality care.
yeah,
Now, the good news for leg and foot, certainly for the leg ulcers, is that the National Wound Care Strategy Programme published the leg ulcer bundle, and in there it lists the metrics that should be measured for quality improvement. There's not a huge number of them. And the good thing is they have all been tested to make sure, A, they can be collected, and B, they can be reported on. So we know these metrics work as improvement
yeah,
metrics. So unfortunately, the program ended before they were able to do the rest of the work for things like foot ulcers. But
yeah,
again, there are metrics there for diabetic foot ulcers, because that's been developed by the diabetes
yeah,
team. So we haven't got the whole answer, but given the size of the leg ulcer population, it makes sense to at least start doing that, so that
yeah,
we're all starting to measure in the same way. So I would definitely go and have a look at the leg ulcer bundle, which is on Futures NHS, to see what's in there, and to start measuring those metrics, make sure they're being
yeah.
coded in the right way.
Because that brings us nicely on to the Legs Matter freedom of information requests. So
It does indeed, yes.
it does. So these, as you well know, Legs Matter are planning on um, submitting freedom of information requests from commissioners and from providers, just so we can try and find out who is providing, who is measuring this, who knows how many patients they have with lower limb problems, not just leg ulcers, edema,
Yeah.
non-diabetic foot ulcers, non-cancer related edemas. So do organisations know? So this is the plan, as you well know, for Legs Matter, to try and find out what data is out there, who has a better grasp of their own data, so how many patients they have, what services they've commissioned, do they even know what services are out there and whether they're effective, and do they, because it's one thing, isn't it, having a service, knowing the standard, but then you need to know whether you come up, do you meet that standard? So, and it's going to be really interesting as to how many organisations can answer all those questions. And I think it'll be quite telling nationally as to where the bigger pockets are, so to speak, which ICBs, which providers have a better grasp of what's happening and what they're paying for and how good it is.
I don't think we're expecting many organisations to be able to come back with a precise answer. And
Yeah,
that's okay. I think some honesty
yeah,
around this is really important. I think it will be helpful to get a measure on who is trying to do something about this. And there will be comments boxes. We're hoping
yeah,
people say, we don't know. And we're hoping they'll put in the comments boxes, but this is what we're doing in our area. Just to try and get a sense of, is this being seen as a priority? Because given that wound care we know, is about 50% of community nursing, and given that the policy push is to get more care out into community, and given that we know that most leg and foot ulcers can be healed far quicker than they are being healed at present. We were stunned by the healing rates in
yeah,
our implementation sites. I can't remember off the top of my head, but it was it was fast. And because they were getting to people quickly and they were turning it around before it became a big issue. So we know that actually, if you start monitoring this, this is something, improving your lower limb care is something that releases capacity in community services, and that releases capacity for other health issues. And we know that's what the health secretary wants. So this is
Yep.
probably the single biggest gift, apart from the alleviation of suffering and misery for those people having to live with
Yeah,
leg and foot. So
that's the risk, isn't it? When you, because what we don't want is to completely focus on data, because there's humans attached to the end of this data, and it's such a
Yes.
balance, isn't it, to have numbers and spreadsheets and performance and outcomes, but also the softer data of quality of life. How is this
And our
really
patients
impacting on
satisfied.
people?
Yes.
Yeah.
But the trouble is, I think it's, speaking as a nurse, I think there's always one feels one is being a better nurse when one's being very caring and very engaged with the patients.
Yeah.
And within that, there is a risk that we underplay the importance of good quality data. Because
Yeah.
ironically, by doing that properly, we actually help patients get the services they need and deserve.
Yeah.
So there's
It's
that
that
balance,
balance,
isn't there?
that science and art, isn't it? Because
Yes. I
the
used to
art
job
is
share, I used to job share years ago. I'm still very good friends with my job share partner. And one day our team said to us, "Oh, my job share partner, she's so good with the patients. And Una, you're so good with paper." And it felt like an absolute stab in the heart. But actually, I would argue both are. I hope I was also fairly good with patients. They seem to like me. But I seem to do some good. But equally, I would argue that being good with paper, I say paper, but being good with that is really important.
yeah.
Don't underestimate. You are still a caring clinician if you're
Yeah.
caring about that side of things as well, because it's the only way you will actually get those good services that you really want your patients
Yeah,
to
and
get.
knowing whether you're actually doing a good job and having the humility to say, oh
Yes,
gosh, that's been actually, could I be better at this?
yes.
And
Why have
just
we
being
got so
able to
many
ask
patients who are,
yourself,
yes, who've had this for so long? Why are healing rates
yeah, so the
not as good
patients
as
are
the team?
happy because you're
Yes,
lovely and they come
yes.
in and they have a lovely chat and they feel really looked after. Um,
You want that as well, but it would be really nice
but we
to
need
help
them to
them.
get better. Yeah,
Yes, because they'll be even happier that way.
yeah,
Yes.
exactly.
No, it is.
Yeah, I
So what do you
know.
think? What do you think? I suppose we've talked about what better data can unlock for services and patients. We've talked about better services. But what do
Yeah.
you think we should be saying to our healthcare professionals, decision makers? What's our call to action, do you think, Kate?
My call to action would be, it's hard to choose one, isn't it?
You can have two. Go
I
on,
think
if you need to.
I'll start with one.
Okay.
For the healthcare professionals, it's how good is your care? How effective is your care? So,
And how do you know?
how do you know? So it's like how quickly are these wounds healing? How quick, and it depends what level you're on. If you're a specialist service who are expected to be more creative about the treatments and work at a higher level clinically, it's much more about are they healing or are they not healing? But for more generalists, it's kind of how soon are you identifying the non-healers and referring them on,
And how
and
soon you're getting them
not
assessed?
keeping
Yeah,
them. So
yeah.
really, the call to action for the clinicians, it really depends on what level you're at. But the overarching thing for me is not to accept non-healing. Always question why. And if you don't know, ask somebody else. And if they don't know, ask somebody else. So always ask and escalate and just don't accept the non-healing. And the data makes that jump out at you. If you look at all the patients you've seen in the last 3 months, how many of them are improved or healed? That it should make you think, oh, goodness me, right, let's refer them on.
Yeah.
I think that was a very long answer, sorry.
That's a perfectly good answer. It's a good answer. I think mine is very practical. It's go and make friends with the IT people and find out
Yeah,
how your data is your data aligned to the wound care standard? If not, why not?
yeah,
See if you can get someone to start taking some interest and help you improve the data. You don't
yeah,
need to. The philosophy we took was you don't need a brand new data system. You need to use what you've got properly and as effectively as possible. And in order to do that, you need to understand what the system is and how to work with it, and to get some few mates in the IT who will help you get those good
Yeah.
reports, which helps you deliver what you were talking about actually how
Yeah.
good is your care. The two things marry up. But I just don't think clinicians can do this by themselves. We need to work as teams with our other colleagues. And we
Yeah.
need to make sure that coding and that data entry is being done properly so that we're actually getting an accurate picture. And if not, why not?
Yeah, I just thought, sorry, just to add in
Mm,
before we finish,
I said you could have two.
I know, making friends with medicines management, because their data can
Yes,
tell you how, or give you
yes,
ideas about how good the care is across a
yes,
larger area. So I'm spending an awful lot of money on super absorbent dressings, but not very much on compression. So that should be
yes.
the opposite way around. So that kind of data can really give you clues as to quality, as to where you want to
Open the
focus
box
and
on data.
do a deep
And that brings us
dive.
back to why product
Yeah,
data is important, is what
yeah,
actually, because what you would expect to see if you're trying to improve, again, I'm sorry, I'm a leg ulcer person, but if you're trying to improve leg ulcer care in an area, you
yeah,
would expect to see an increase in the amount of compression. You'll probably see an
yeah,
increase in the amount of compression products being used, but then once you get your healing, you should see that steady out and drop. So is
yeah.
that happening? And if not, why not? Yes.
And for lymphedema, if it's better managed, should be less
Yes.
cellulitis. So
Yes.
it's
Of the
that
foot,
the full take on
referrals to
program.
vascular, early
Yeah,
referrals to vascular. I mean, the number of vascular surgeons who've said, I just wish they'd get them to me quicker.
yeah,
So it's about trying to get the whole system flowing, isn't it?
it
So
is.
maybe this time next year, Kate, who knows but I am hearing from the ground, I am now hearing some real green shoots of people starting to do this. There is interest. So it just needs to carry on, just needs to carry on.
Well, thank you, Una, for the chat.
Thank you,
Always a
Kate.
joy
Always
to
lovely
pick
to
your
see you.
brain.
Lovely
Thank
to
you.
see you at any time. Take care. Bye.
Bye. So that was the chat about the data. Julie, we've had a few questions, which is lovely. I see that you picked up on Sarah's point, which was really interesting. So Sarah mentioned the director of ops recently said clinic is always cheaper than home. And Sarah's excellent point is only if the person in clinic knows what they're doing, which comes back to that point Una and I made about you need to be able to show that your care is effective, and not just you personally, but your service, your organisation. So I can see that you picked up on that, Julie.
I did indeed, because we see a lot of those sort of comments in practice, don't we, where we think it's effective, or there are comments about it's more clinically effective to do it this way, or it's more sustainable to do it that way, or whatever it might be. And if I were hearing comments like that in practice, I'd be challenging those people to say, how do you know? Do you know something I don't, in terms of what the data is showing you, what the cost analysis are showing you? Because clinically, that would be really interesting and really powerful information for us to know, to understand actually, should we be doing things slightly differently then? If our ops managers are telling us that it's cheaper to see people in a clinic, then that's game on for us, isn't it? Because sort of nationally, the push around certainly lower limb care is to start thinking about dedicated lower limb services. So I don't know, Sarah, whether you want to expand on that by coming onto the call, or sort of telling us more in the chat so we can share it with colleagues about what's sort of informing that sort of comment, because we do hear it a lot in practice.
It's interesting as well, because when you start talking about clinics versus the home setting, there's the obvious savings in time, travel, etc. But then some areas provide transport, some areas don't. There's hidden expense to clinics, and two different areas one who provides transport will have a much bigger outgoing to one who doesn't.
Yeah,
No,
indeed.
we can't, Sarah, sorry.
Oh, sorry. Yes, I was just saying if you could hear me, so you can hear
can
it.
now.
We can hear you now, Sarah.
Yeah. Oh, thank you.
Oh, thanks for joining us.
No, I mean, tissue viability, we've managed the leg ulcer clinics now as part of our service for since 2018. And we've joined the National Wound Care Strategy now for the next tranche of people, of organisations to be looked at, because we know we're not good at data. And then our director sort of says things like that. And that's because they're doing the review of community nursing and they're looking at who's really housebound and who's not. But we've all, it's a very grey area, that is. And so I did suggest that because suddenly they told me that 79 patients are waiting to come to clinic from district nursing caseload. It turns out when we've rung all the district nursing, that's actually 9, they've told us. But somebody's been through some records and but it's not a clinical person, has somehow said there's 79 patients out there, at which point we flipped because we can't get them into clinic. So I said, well, the alternative is we do what we did in COVID and we kept clinics open in COVID, and then we sent out clinic staff to people's homes who couldn't come. And it worked. We know we can do it. It takes longer. And she said to me, Clinics A was cheaper because of the travelling, all of that sort of thing. They're going to somebody's home. And I was thinking, well, no, it could be. And what I can't say is I know our clinics are clinically and cost effective compared to people at home because of the continuity. That's what I think, or we think, but we can't prove it. And if any of you are district nurses out there, I don't want to make you feel in any way that you're delivering something else, but you are delivering something else. And our big issue in community nurses, and our community nurses will say it, and it's evident in investigations, in all sorts of things, that the continuity is not there in some teams, some very big teams, and there's a lot of junior staff out there nowadays, and well, you all know what it's like. And so there's no proof. I mean, the proof that I'm thinking of is that clinics are better than home care. It is when I started 30 years ago and we did the first 4-layer bandaging trials, we can't use that data anymore because the people who came to clinic were getting an assessment and compression and the people at home weren't. So we weren't comparing like with like. And I don't know what has proved, if there's any research that's proven that, recently. Because I mean, we know if we were really good at looking at people at home, we'd be able to hear the leg ulcers. That's fine. That's not a problem. And the people at home might have a lot more comorbidities because they're housebound. There's a huge differences in the populations, but it's just when you're trying to put cases forward for your service, a lot of it is done on just what evidence there is and what your gut instinct is. Not data.
Indeed. And this is why it kind of brings data to the home of the clinician, really, doesn't it? Because I think over time, and this varies across clinical services and organisations, of course it does, but I think my experience of being a clinician asked to contribute to data trawls or data sort of runs, and the sequin is one of those, which was raised in the talk just a moment ago, was that as clinicians we tend to follow the protocol. We provide the data for the national audits and we provide it for organisational level audits, and then we tend not to see it after that.
No, that's when they turned ours off after a year because that year was done. But they've said they can switch it back on.
Yeah, but that, I guess the point I'm trying to make there is that kind of disempowers us as clinicians because we give the data, but we're perhaps not owning the data. And this webinar is kind of starting to generate that discussion and that thought around actually that is our data and it's a meaningful data to inform us of how our services are performing. But when you are thinking about business cases for change, when you're trying to think about can we improve services, can we improve equity of services? So like you said there, Sarah, care is delivered in patients' homes and in a clinic environment. housebound patients perhaps can't get to your clinic, so it's the care is provided by district nurses. But is that an equitable service? Are they receiving the same competent expert-led care in the community as they would in a clinic, and vice versa? So when we are trying to think about that in the context of quality improvement, it kind of goes beyond quality improvement, because I think we've all been involved in QI type initiatives in practice, and yet we haven't really been able to push it any further forward than the more localized project. And I think often what's missing in that is data and the investment in data and clinicians owning that data, and really understanding what it means. And Una, right at the start of that talk, kind of said a lot of people might find data dull, but actually, is it we find it dull, or is it we misunderstand the relevance of data? Because often we're not involved in that processing and business casing. So when your ops people say it's cheaper to see people in a clinic environment, and you're now saying, Sarah, actually, we know we're providing a service, but we're not entirely sure how that fits into the wider system or the wider population of patients. This is an absolute trigger for us to start thinking about, well, what is the data telling us? What's available to us? And owning that. It's your data, you're collecting it, you're seeing the patients, you're collecting that patient-related data. And thinking about it from a wider organizational point of view. And just on a second point, we talk a lot about national data metrics, but actually, what does that mean to your organization? You know, I work with a lot of ICBs who don't yet have a total handle of who their wound population is. Or the provider organisations don't have a complete handle of who their wounded population is. They can tell you it within their own caseloads, but actually, what is the wider system? Where are these patients in the wider system? Because they'll all be moving around the providers, like acute sectors, primary care, community care, social care. And we'll all be collecting data on that part of that journey, but it's not linking together. So you'll also find duplicate data, which I think maybe you might have been referring to with the 79 patients that are not receiving care. So there's lots of variables in this, which is why you've often got to start from foundation level, and it takes a lot of time, it takes a lot of investment, it takes collaboration with your business analytics team to get it right from the start, so that you're not trying to formulate templates as you're delivering the QI project. It's a bit chicken and egg, isn't it? What comes first? Your data templates to make sure your data is consistent and robust versus actually just getting on and doing the do. And I think we're good at doing the do, but perhaps not maybe building the foundations that are going to make that business case at the end of it for change.
I think for me, sometimes when you start really getting into it and you find it interesting and it's your data and you're really getting going with it, I've done this in the past, you can sometimes get a little bit carried away and you want more. Oh, that'd be interesting. But you've really got to keep it simple, because you can very quickly lose the generalists who are actually inputting, coding every day, very busy, seeing palliative patients, catheter patients. And if you want them to consistently code properly, use the right templates, everything else, you've got to keep it to you can't overcomplicate it and just add more and more and more just because you find it interesting. It's a real balance between having enough to demonstrate what you need versus not losing the people who you need to input the data in the first place. Because if they're not on board, it won't be accurate, and you're lost.
Say in response to that, Kate, also make it relevant to your organisational priorities.
Yeah.
Because if you are then asking, or you're doing a QI project or improvement opportunity to present a business case for change at the end with your commissioners or with your meds optimization or whatever it is you're trying to achieve, then think about what their priorities are. What I've learned from moving from clinical more into sort of program management type roles is that you need to speak the language of the people you're trying to influence. So what is it that they will be looking for within that data? What's going to be exciting to them? What's actually going to turn their heads and say, actually, we need to listen and we need to take this seriously? And that can only come by bringing in your stakeholders at the start. So who is it that's going to support you in that data? Who's going to be your champions then in formulating those templates and actually making that data meaningful to the wider organisation?
Yeah, because it's not enough to say we want data. It's like, well, what for? What are you going to do with it? Who, like you said, who's it going to be aimed at? Are finance going to be interested in that really? Because they want to know how much it costs.
Yeah.
Yeah.
And like Sarah said in the chat there, I think we have overcomplicated data and we're all a bit bamboozled by it and actually a lot of the time non-compliant with it because there's just so much of an ask when you're out in clinical practice. You know, you haven't got time to fill out many forms. You haven't really got the capacity even to trawl back retrospectively, which is why moving forwards, that data set or the ability to pull data is really, really important.
It's got to be easy, hasn't it?
Yeah.
Just to sustain it. Because I think, I mean, we've all done QI projects that have had amazing results and then suddenly tailed off over years. Trying to sustain that level of success, for want of a better word, is really difficult. And I think if asking for more and more all the time from people is it's not going to last. It's got to be simple.
Yeah, but the way of managing that is to ask those people that are collecting it, what are the barriers? What do you need to see from this? What's going to help you collect this level of data? And this is why it's important. You know, people probably would engage more if they understood why they were having to do it.
Yeah.
And if it was part of a much greater good.
Yeah, I remember some DN teams I worked with years ago got quite competitive. It's quite interesting. When you had the data, they wanted to beat each other, which was and that really drove them on. Also, different personalities everywhere, but it just find out what drives people on. Do they want to beat their neighbours? Or what is it that gets people, like you said, engaged?
And it is difficult, Sarah, isn't it? That attention does move on, and we do know that it's very obvious in wound care that wounds are not sexy. You know, they're not cardiovascular disease, they're not diabetes, they're a symptom of, but what we do know from the national data and all the work that the National Wound Care Strategy Programme has achieved over the last 5 years is that wounds are crippling the NHS system, and of course they are crippling patients quite literally in some cases. So and as Una had alluded into in the recording, is that we are starting to see more motivation and most certainly it becoming more of a priority on the agendas of regional ICBs, but also NHS England as well, where we are seeing commissioners and policymakers saying we have to make a change, we have to see transformation within the NHS. And this is all sort of part and parcel of that. We needed something like the National Wound Care Strategy to set the standard, to set the benchmarks about what we should be aiming for. And now it's our role to continue to fly the flag as we are this week, Legs Matter. You know, fly the flag for improving our patients' outcomes. And also, on the reverse side of that, improving our workforce's well-being. It's so demoralizing out there to have so many patients suffering with wounds and not being able to provide the level of service that we want to. So, it's a really important agenda, and I think, we just keep needing to fly the flag for that and using our data to show that it is evidence-based and that it is working out there.
So I'm just thinking, I've heard Alison Hopkins say this before a few times, that sometimes at ICB level, even if you have the data, sometimes it's the change that is needed is seen as too difficult. What are your thoughts on that?
I think it is difficult. I think it is a challenge because what we're asking organisations to do is think creatively and think differently about how they're providing services. And when you are at the very limit of your service capacity, when you're at the workforce is at the very limit of their abilities to deliver care every day, it's very difficult then to think, what is this transformation, and think creatively about how you can do things differently because you're so immersed in delivering, the service spec every day. But I think ICBs are probably not the right people to be asking to lead that transformation. I think it needs to come from providers, and I think it needs to, of course, involve the ICBs as stakeholders because they are commissioning. But it's about, we talk a lot about resilience in clinical practice. We talk about clinicians being resilient under the pressures of the NHS. But actually, let's think about system resilience. Let's think about, is the system resilient enough to go on board with this level of transformation? Is it ready for that transformation? And I found that people, organisations, ICBs need to be ready to make that change. So, Sarah, you mentioned that your community services are under review at the moment, and they are in my region as well, where ICB commissioners are trying to think about review the services that are providing wound care and trying to think about where is the release and capacity? Are we doing this in the right way? Are the pathways correct? You know, are capacity tools being used to the level that they could be, etc. I think what's really important also is that we're not necessarily meaning that you need to set up new practices or new clinics to deliver this. What we're trying to engage with at organisational level is how you can work differently, and think differently about how you're doing it. And in fact, I would probably say with nearly 6 years of the National Wound Care Strategy, a lot of clinicians are probably delivering elements of this programme already, elements of the standards already.
Yeah.
So actually, we're not saying we're starting from scratch. On the whole, I would say most clinical organisations are already delivering the standards at some level. So it's about taking time to really understand where the gaps are in your organisation. Your data would help you with that, but also going back to sort of simple QI methodology around scoping exercises. Who delivers what, how and when? And actually, what are we delivering? What aren't we delivering? What do we need to do to get up to that standard? And data will support you with that, but actually data might be your first point. Might be the first point of call. You need to get your data sorted before then you know how you're going to position that transformation. And I think that feels like an enormous task in the current NHS because it's not well understood. Wound care is not well understood because it's almost sort of a new thing on the block for most people, where it hasn't been for us for years. Because we've been, how often have we had these conversations over the years? But it's a newer concept to a lot of sort of commissioners and ICBs. We need to educate those ICBs on what they need to be thinking about, and we need to go to them and actually direct what needs to happen. We need to be the leaders on this. We need to lead that conversation, and we need to lead that transformation, and get the right stakeholders on board at the right time. So in answer to the question, yeah, ICBs are probably quite dismissive because they don't understand it fully. Yeah. Some will, some won't. You know, like I say, we've had a lot of ICBs engage really well on the programs we've run. But I just think also you need your champions. Stop trying to tackle the whole ICB. Think about who your champions will be, and link in with them, because they can do the influencing and you can work with them to develop what your concepts are.
Lovely. Just see if there's any more questions in the chat. No, I was gonna I suppose we've talked about barriers, haven't we, in that clinician engagement on the ground. We've touched on that. We've touched on not wanting to overcomplicate things. Yeah, is there anything else that you'd like to mention, Julie?
I think just put on the point of the ICB as well, just going back to the point I made earlier, think about your priorities of your ICB, because we know the ICBs are restructuring again at the moment. So in terms of their long-term planning, it's going to be quite difficult for them to think about transformation at this level within their sort of planning. But think about, you know, if you Google your ICB, you'll see their priority planning online, and you'll be able to think, actually, where does this fit within? And although wounds should be a standalone issue and they should be recognised as such, think about the other agendas that your ICBs have had around net zero, around the core 20+5 agenda, which looks at inequalities in services and the population. Think about how it links into the priorities around chronic disease management, so things like cardiovascular disease, diabetes, think about how it ties in to their prevention planning. So you've got to kind of think creatively about, okay, in order to get the wound agenda recognised, how is this going to fit in with their priorities? How can I build the business case to say wounds certainly fit within this priority because X, Y, and Z? And if we do X, Y, and Z, then we know that we could make an impact to this agenda. And for clinicians, for some it won't be, but for majority, I would say, because it certainly was for me, and it wasn't until I got into this more program management role I started to think differently. It's not a natural process for us to start thinking this way, because we do a lot of localized quality improvement work, so we can make a real direct impact to the patients and our practice. But actually, when we're thinking about more system-wide impacts, it's not a natural flow for us to then start thinking about how do I interact with other services that would be seeing these patients? How do I collaborate with stakeholders at ICB level to demonstrate what we're doing at practice level and demonstrate how that fits into a wider system sort of priority? And so it's an interesting one, this webinar, because we talk about the rawness of data and the rawness of collecting data, but actually thinking creatively with data about how you can use it to your advantage to influence the wider policies and the wider priorities, perhaps isn't such a natural default then for clinicians, but
It's
could be really
interesting.
powerful.
It's interesting what you said about the inequity of access. So, like from Sarah's comments before, that was, you could see it at the most simple level of housebound versus able to get to clinic. But just from it made me think of some work that Accelerate have done before across North East London, where you could see that patients with learning disabilities were less likely to be in compression, and patients who were the older patients, so 85 plus, were much less likely to be in compression. And it's just interesting things like that, linking pockets of obesity to social deprivation data and the link between edema and obesity. And like you said, you can link in with their priorities because many of these groups have inequitable access to high compression for those that need it, certainly.
And Sarah, you're right. The transformation work around ICBs, they are likely to become more strategic commissioners rather than sort of the priority setters for local providers. It's going to be even more important for providers within that integrated care system to work more collaboratively and think about the pathways of care and the data collection across those pathways, so that again you can support the ICBs in how they're commissioning services and thinking about their commissioning priorities.
Yeah, sorry. Oh.
Yeah, go Sarah.
Sorry, I can only see you two on the call, so it's almost like I'm just talking to you two.
Yeah, you and me both. We're all like that, yeah.
It's not all about me, honestly. No, the thing about the ICB, we had a small transformation team developed in our organisation, and in our restructure, the main guy's been made redundant. The other two are moving back to the business unit. So it was only 3 people. But I was thinking about your comment about where does the transformation come from? So we had a transformation team, but we had to tell them what we needed to transform and how. All they did really was contact me and said, how many patients have you done yet? How many discharges have you had? How many of this, that, and the other? So they sort of were there to support us, but it was difficult for me to see their involvement other than administration, really. And going back to your point, it's us really who say, well, we could do this like this. This is possible like this. This is the latest thinking about how to treat wounds. That comes from us really, with support from people like yourselves, with data, statistics, ideas, sharing ideas, policies, etc. But it's hard to. So I must have been feeling in a very positive mindset, because I said to our team just last week, because we'd been involved with a lymphedema meeting that had been very difficult. We treat lymphedema, we always have. We treat people without wounds and lymphedema because we have the contract for compression, which is a very sort of unusual thing. And we were with another area who don't see anybody if they don't have a wound, and they don't treat any, and they say we're not commissioned to do this. So I said to our team, it's not, commissioning can't have every single detail in it. Sometimes it isn't actually about being commissioned and having the money for it. It's about our brains behind it, of what we can do and doing it. But as I say, I was in a positive mindset that day. It's like you say, when you get bogged down in all of the day-to-day things, it's getting people to think about it differently, and it's hard.
It's really hard.
Yeah.
It's really hard to
Yeah.
keep motivated when you feel like you're constantly up against a brick wall. You're constantly fighting for this and fighting for that, and you feel frustration that at the center of everything we're trying to achieve is a patient, and it is really frustrating and it's really hard. But I genuinely feel that the worm is turning. I genuinely
I do.
feel that nationally this is absolutely on the agenda of NHS England, and ICBs are starting to recognise the significance of not having services that can deliver the standards of care we need for patients with wounds. And I think as a collective voice, we can start continuing to push that agenda. It's really difficult at a local level if you haven't got that, though. And as I said, this is where you need to start recruiting your champions. And they may not be an obvious nurse, they may not be an obvious wound care champion, but think about in your wider circle of influence or your wider stakeholders, who else do you need to onboard? And it might be you need a steering group, you need a working group to start bringing that collective voice together. Because it is hard. But we know from the National Wound Care Strategy that the first tranche implementation sites, we know from the Health Innovations Transforming Wound Care sites that it works. It's a proof of concept. We have, collectively, both programs saw nearly 6,000 patients through those programs, where we demonstrated healing rates of up to about 60% within 12 weeks, because those patients received strong compression in a timely way. And so we have that evidence now to suggest or to proof of concept. What we now need to do is to start implementing. We need to stop piloting it and start implementing it. And that's the challenge. It's about recruiting your champions or recruiting your stakeholders to demonstrate that this is what needs to be done at a local level. And from a data perspective, Transforming Wound Care, we started with about 21 metrics that we were asking our sites to collect. And every metrics call, their heads were in their hands thinking, oh my God, how are we going to achieve this? Because we were thinking about it from a clinical perspective, we were thinking about workforce capability,
Quality of life,
everything. Let's get everything in. Well, we've got the chance. And discovered mid sort of program that just was absolutely unrealistic. But that's what the program was about. It was a learning journey. It was almost that PDSI cycle. And what we've come out with now is that with the next phase of that Transforming Wound Care program, we're looking at just 5 metrics. That's all we're asking our sites to collect, which is around the clinical pathway, which is the identification, the assessment, the treatment, the healing, and the recurrence, around that sort of National Wound Care Strategy lower limb pathway. Because that is where the transformation happens. It will be within that clinical pathway. So if we can demonstrate that again is working, and we're keeping it as streamlined and as simple for clinicians to collect that data, that's where the transformation is going to take place and what we need to evidence.
There's engagement with only 5 versus 21 metrics.
Sorry.
Has engagement been better with only 5 metrics versus 21? Is it an easier sell?
We're about to do it. But I think, but actually towards the end of the last program, which ran for 2 years, the Transforming Wound Care program ran for 2 years. Towards the end of the program, we were narrowing it down to more critical metrics. And actually, yes, we found that the data flowed a lot better. And interestingly, the feedback from those sites there were 8 sites that took part in that programme, organisations from ICB down to primary care sites. Clinicians themselves were reporting that this was absolutely transformational for their own practice and for their own knowledge and development, because they started to see the power of data once they'd got it, and once it was consistently relevant to their practice, they were reporting and feeding back really positively how motivated they felt by actually having this in their toolbox, by having this data. They felt empowered by it, because finally they could see the impact of what they're doing, because we know every day we're making a difference, but we can't evidence it necessarily, or we can't consistently measure it. So for the first time ever, really, a lot of these clinicians were saying we can now finally evidence what we are doing every day, because that will also inform service reviews. It will also inform service evaluations about how capacity is used and where it could be best used.
That was a lovely, positive, almost ending. We've only got a few
Ending note,
minutes
yes,
left.
absolutely. We've just got to be brave. We've got to see data as a friend.
Yes, love the data.
Love the data. I wouldn't profess to love data, but I have embraced it. I still need the help from my business analytics people to help me make sense of it sometimes, but I have embraced it.
Thank you, Julie. That's been so insightful. And so thank you for joining us this evening. Just before we finish, it links beautifully to what Julie mentioned about champions. So this week we have launched the Legs Matter Champions programme. So it's a great way of getting clinicians, non-clinicians, anyone from a carer in a residential home to a family member to a nurse to a doctor to anyone who just more involved and empowering, and really empowering patients, empowering families, just really selling the message of Legs Matter. So if you go, Kerry and Sue might pop it in the chat now, the link to the Legs Matter Champions. Thank you. So it's a great programme, and we're really hoping it's a roaring success. And I think it's just a great way to demonstrate that you are really flying the flag for good quality lower limb care. But thank you so much for joining us. Julie, fabulous as always. Thank you. And have a lovely rest of your evening.
Thanks for joining.
Thank you.
Thank you.